Okay. So we have been onto this level. Have I got everybody here again? Or everybody's gone? I think everybody's here, yeah?
Yes, sir. Everybody's here, sir.
Okay. So what type of bank cards do you know? Sorry, letter J, do you know? So we said that the letter J Bristow procedure, where you just take the bone, has gone now. So there are two types of letter J. There's an anatomical and there is a non-anatomical letter J. Okay. So the non-anatomical is the French version, because letter J was a French surgeon, and in his hospital in Lyon, Gilly Walsh is now continuing his tradition, so they do a non-anatomical. But why do we do the conjoined tendon with it? Nobody told me that. Why do we take the conjoined tendon? The bone makes it an off-track lesion into an on-track lesion. What does the conjoined tendon do?
It provides a sling effect.
Yes. How? Very good. You guys are very good. Yeah. How?
By restraining the humeral head from dislocating anteriorly.
No. So when you're in this position, I can't show you this video. I'm not sure where you can see me, but you're in abductional external rotation. Yeah, that's where the sling comes into play. The sling will only work if you're in abductional external rotation. So therefore, we're not only using a bone to work at the level of your elbow, but you're also doing a sling effect. So when you go into abductional external rotation, it won't fall off. Okay, so it's a double whammy, as you call it.
As far as we know, we also take the coracoacromial ligament with it too. So it provides triangular support.
Not true. If you're doing a French version, which is the non-anatomical version, then yes, you will. Joe DeBeer described the anatomical version. I'll just show you a slide and you can understand them. Yeah, okay. If my computer still works. Yeah, there you go. So the original latter J was described. This is the undersurface of the arch, and there's the coracoacromial ligament going from here. So they used to cut that with the conjoined tendon and close it, and the soft tissue that was with the coracoacromial arch was reattached to this labrum. So that was the non-anatomical version of it. Okay, but the problem with the non-anatomical was that you used to have a bump. Okay, and then they used to have arthritis set in very quickly. So Joe DeBeer in 1990 described the anatomical version of it. This is the undersurface of the coracoid, and you rotate it in such a way that it faces anteriorly. So nature has provided that curve to match the curve of the glenoid. Okay, so when you do it this way, then there is no incongruency, and it becomes an anatomical structure. Okay, so in the exam, there are two types of latter J that you have to talk about: the non-congruent one and the congruent one. The non-congruent one gives you the triple effect, which gives you stability, the anterior inferior stoppage from subluxation, and the coracoacromial ligament to the labrum to give you a triple effect. Okay, you don't get that effect in the anatomical one, which is a congruent one, where the bone is congruent, and therefore it gives you the two effect from going anteriorly and superiorly, you know, like abduction and external rotation, and from the bone making it making the what you call the engaging into a non-engaging lesion, like this. Okay, so you change the tracking to the off-tracking into the tracking lesion. Okay, sorry, I got distracted.
Just
walking down the corridor. Yeah, sorry. Go on. You were asking
just a question.
Yeah.
Yes. How much coracoid we need to get for a proper bone stock?
Okay. So
is it any defined?
We should have two screws going through it. Okay. So just to show you pictures again, this is the congruent and this is the non-congruent one. Okay. Can you see the difference?
Yes.
It matches the curve of the coracoid, yeah, and it works like that. Yeah. That one is rotated here, so that coracoacromial ligament can be stitched into the labrum to give you more strength. Okay. So I'll tell you now, you do a subscap approach. You don't cut anything, but you split the lower third and you open the joint. When you go into the open joint, you will take the coracoid and free it completely. Okay? So you will cut it to where the elbow of the coracoid is. Do you understand that? The elbow of the coracoid. The coracoid then goes from being in the front, goes posteriorly in a curve. Do you understand that?
Yes, sir.
Yeah, so you have to cut it where the elbow is. Okay, and you have to have enough to put 2 screws in there. Okay, so this is an anatomical, this is a picture from a cadaver that we were doing, that I've taken for you guys to understand. But this is an anatomical where we're going to cut it and then turn around to make it anatomical. So if you look at this picture here, you cut it where the elbow is. Okay, so you take bone that long. Okay, and you fix it inferiorly, as inferiorly as it can go. Because, do you know what this is called? This lesion, this is glenoid. There's a name for this. It's called an inverted pear. Do you know that?
Inverted pear. Yes.
It's the inverted pear means there's less at the bottom and more at the top. So when you do the repairs, you fix this bone into the bottom to make it back into normal again. Okay?
Excellent.
So this is what it looks like eventually. Sorry?
So the undersurface will come interiorly.
Yeah. So you can see this, the undersurface and interior. So the curve is now matching the glenoid.
Yeah.
Okay, so I don't do non-congruent repairs, but the original description was by Latourgé, who was from Lyon, and he described a non-congruent repair. However, Gilly Walsh in the 90s added on the triple part of it, where he took the coracoacromial ligament with it and stitched it with the labrum. Okay. So next one. So who wants to play now? So tell me when you guys are bored and we can stop. I mean.
This is an X-ray AP view of the right shoulder, showing AC joint dislocation.
Don't use that one. No.
With
joint disruption. Okay.
AC joint disruption with the loss of with the tear of
okay, don't look at
clavicular joint and the costoclavicular joint.
Yeah, so don't look at this picture.
And it is type 3. It is a
okay. So now less than 100. So your type 3.
It is less than 100% of.
Do you think it's less than 100%?
Yeah.
Do you think it's less than 100%? It's not. It's not less than. It's more than 100%.
It's not more than 100%.
Yeah. So in the do you know classification to sort of, if I was doing the exam, somebody showed me this X-ray, I would say that this is a X-ray of a skeletally mature person showing AC joint disruption of the right shoulder, and I'll stop at that one. Okay.
Okay.
And then the next question is going to be: do you know any classification of AC joint disruption?
Rockwood Green.
Yeah, Rockwood and Green classification for AC joint disruption.
Can you tell me?
Number one is the acromioclavicular joint sprain, tear, and the intact costoclavicular joint, and the sprain of the costoclavicular joint. The one, and the two, the AC joint, AC ligament and the costoclavicular ligament both get tear, and in the number 3 there is 100% superior dislocation, and number 4 is the posterior dislocation. Number 5 is more than 100% of superior subluxation, and number 6 is the inferior dislocation.
Okay, so my understanding is 1 is strain or sprain, 2 is the lateral ligaments are gone, 3 both lateral and medial ligaments are gone. So i.e. the acromioclavicular are gone in the 1 and 2, and in 3 the conoid and trapezoid are also gone. Okay.
Yeah.
4 and 6 are stuck into either forward or backward, and 5 is more than 150%. Is that easy to remember?
Very true.
Huh?
Yeah.
Exactly.
Okay.
Yes.
So how would you differentiate a 4 and a 6 from a 5?
In the 5 there will be a deltoid fibers will also be torn, so there will be more than 100% dislocation superiorly.
Yeah. So but it wouldn't look. So how do you know that this is not a 3 and it's not a 4 or it's not a 6?
When doing abduction, doing abduction, the AC joint will be relocated. If there is not, no.
So now on the clinical examination, even in A&E, if there's only 15 minutes old injury, all you have to do is put your hand on top the AC joint and push the elbow up. Okay, so the dislocation
will be reduced.
3 and a 5 will reduce because there is no soft tissue from stopping it. So you can see clinically, visually, that when you put your hand on the AC joint and push the elbow up slightly, the whole weight is on your hand and then the AC joint will be reduced. In a 4 and 6, it will not reduce purely because it has got stuck in the soft tissue. Okay.
Okay.
So,
Okay.
in a Campbell, it is written that if you give in abduction and external rotation in the 3 and 5, if to see the deltoid is intact or not. If in the 3 deltoid is intact, in the 5 deltoid is not intact. If the deltoid is intact, the AC joint will be
Campbell it takes 10
relocated.
years to write a Campbell, and it takes 10 years to get published. It's at least 20 years old, the evidence on Campbell is. So
Okay.
I'm telling you, clinically, you see a patient with an AC joint disruption, try to abduct and externally rotate, and he's going to hit you with a slap. He's too painful, he won't let you touch it. However, if you take the support of his elbow and hold it, he will allow you to push it because his pain will get better. So you cannot aggravate pain, by external rotation, abducting it. The simple thing in the exam to tell them is the difference between the 3 and a 4 and a 6 is that if I can reduce it by lifting the elbow and taking the weight, because the clavicle is not gone up, it's the whole shoulder that's gone down. Do you understand that? So the weight of the shoulder is pushing everything down. That's why the clavicle looks high up. So if you can reduce that, then it's not a 4 and a 6. Okay?
Okay.
So this is what we've just discussed, yeah? So how are you going to repair this, sort this out? What are you going to do with this? So a 4 and a 6 is an emergency. You must understand that. A 4 and a 6 is an emergency. You have to do straight away. The 3, 5, if you want to operate on, you can do it within the first 4 weeks.
Yes. First, I will ask the patient occupation, whether it's an athlete, a sportsman, or a laborer, or he is a shopkeeper, or if he is, it will depend. The treatment will depend upon the patient activity. If the patient is very active, highly mobile athlete, I want to repair it in the type 3. But if the patient is having shopkeeper, having a sedentary lifestyle, I will conservatively manage the type 3. But in the type 5, I will repair it.
So I will repair everybody in type 3 I will actually give them a conservative approach for the first 4 to 6 weeks anyway. Okay? If they're still painful, then I will repair them. However, most of them, about 90% of them, will heal if you give them a good cover and cuff and good physiotherapy. Okay? So in my books, I will only repair a 3 if I'm pushed into it, and maybe if he's a high-profile athlete, then I can repair him. But most of them are managed non-operatively. So the 4, 5, and 6.
Even 5.
Sorry.
Even 5.
No. 1, 2, and 3. Okay.
Okay, 1, 2, and.
I will manage them non-operatively. If they're still symptomatic, I'll go back to the 3 and see if I can repair them. If he's an athlete or a high-profile athlete, then I will manage the type 3 before the 4 weeks are over, so I can give him a chance of healing. Okay. So in the 4, 5, and 6, I will repair them straight away. The 4 and 6 are emergencies, and 5 I need to repair within the first week. Within the first 4 weeks. Why is that?
Because if you do not repair it, it will having a chronic arthritis or the chronic pain
ligaments,
in the
conoid and trapezoidal ligament will heal within the first 4 weeks if we bring them together. If they go beyond 4 weeks, they don't have a potential to heal, then we have to augment them with a graft or something else. Okay, so this is a very nice picture actually. I've just realized that if you look at the 1, it's strained. If you look at the 2, the lateral bit is gone. If you look at the 3, the medial bit is also gone. So that's an easy way to remember this, like, isn't it? Yeah.
Yes.
And in a 4 and a 6 is gone and stuck itself into something, and the 5 is 150% or more up. Okay, but the conoid and trapezoidal ligaments is very important. Okay, so what are you going to repair this with?
If it is acute injury, I will repair it primarily and augment it with a hook plate or a Bosworth screw. Or if it is
the problem with these
chronic,
what is the problem with these two? With the Bosworth screw or with the hook plate? What happens?
You have to remove it after 3 weeks. You have a second operation.
Yeah, very good. Why?
Because it will impinge on the subarachnoid space, and having a chronic maybe.
Don't run. Listen and understand. We've got time. We can learn all these things. When it comes near the exams, then we can do proper Viva system. At the moment, it's Viva plus teaching going on at the same time. So why do you need to take the Bosworth screw out and the hook plate? I know you said one of the reasons was impingement, but what's the other main reason why you take them out?
Hardware problem, hardware impingement.
No, go back to anatomy.
So there may be a loose and a cut through the.
No. See, how much of abduction you have on the shoulder?
180.
Yes. So of those 180, how much is happening at the glenohumeral joint and how much is
120.
Yeah. Where is the next 60 degrees coming from?
120 is from the glenohumeral and 60% from the scapulothoracic.
Yeah, but the clavicle is important also, isn't it? It rotates 1 degree for every 3 degrees of elevation. Yes?
Yes.
Yeah, so if you fix the clavicle onto the acromion with a hook plate or put a screw through it from the clavicle into the coracoid, what's going to happen?
Then the abduction will be limited.
Yes, so you will never get full function. So when people tell you that they've done Bosworth screws or they've done hook plates and they have full function, then they are lying, isn't it? Because you and I know very well now that if the clavicle does not rotate, it's not going to go beyond 120 degrees. Yes?
Okay.
So you have to take the Bosworth screw or the hook plate out to give the person full function, i.e. he will get 120 degrees, but for him to get 180 degrees, the clavicle has to rotate. So you can't have a Bosworth screw or a hook plate to stop the clavicle from rotating.
Okay, fine.
So that's the reason why we take metalwork out. So you want to give full function. Okay? I bet nobody ever told you this before, and you never thought of it. Did you ever think the clavicle rotates?
Yes.
You did think that the clavicle rotates? All right. All right, but at least you will all pass exams. I know you've got good concept, but at least I give you a concept, so in the future you will also be a better surgeon, like, isn't it? That's why Sufyan is very good with basic concept. You know, he needs to know everything rather than operate. Okay, so you've just said that we put a screw into it, which is a Bosworth screw, or you put a hook plate into it. And the problem with these is it will work if you do it then how long after an injury?
Initial 4 weeks.
Yes, because the conoid and trapezoid ligament has the potential to repair if it is repaired within the first 4 weeks, or it's allowed to heal within the first 4 weeks. Okay, so once the 4 weeks are gone, these operations are not going to help you. You understand that?
Yes. Then we have to augment it with some graft.
Yes. So what are the other options you have?
If it is more than 4 weeks, I can take the palmaris longus graft and augment it with a fiber wire also. And if the patient is elderly and have a sedentary lifestyle, I will have a modified waiver done procedure.
There are 2 types of procedure you can do. You can leave the shoulder anatomic, or you can leave the shoulder non-anatomic. Okay. Is that agreed?
Yes.
A natural graft, or you can use an artificial graft. So if you do a non-anatomic repair, that's called the Weaver Dunn procedure. Okay?
Yeah.
So you're taking a ligament from where it should be and putting it somewhere else. The problem with these is that the conoid and the trapezoid ligament after 4 weeks don't heal, right? So a lot of stress is put on one ligament. So sometimes you have to augment this also, not just do a Weaver Dunn on its own, but in most books it's written on its own. But if you're a thinking person, if the conoid and trapezoid ligament have got no potential to healing, and you've done this repair, and you've taken the acromioclavicular ligaments out by cutting them to, or there's no chance for that to heal, then there's a lot of strain going on this ligament, isn't it? Correct?
Yes.
Yeah, so you have to augment it, but this is a non-anatomical repair, okay? So we are in a modern world, we'd like to do anatomical repairs, so I have not done a Weaver Dunn in over 12 years. And I don't think so most people do a Weaver Dunn, but you need to remember that non-anatomical procedure. Okay, so what's the anatomical procedure? So
anatomical procedure will be a allograft or a autograft and augmented with a fiber wire.
So I do these arthroscopically. I do them by putting a button on them. So it's the same process. I do them 4 weeks. Before 4 weeks, I put this arthroscopically. If they're more than 4 weeks, I put a graft in. But in your person in Pakistan, you will tell them that you will replace the ligament by augmenting it with an artificial or a hamstring graft. So palmaris is not used mostly. Most grafts are taken from the hamstring, whatever you do. Okay, so if you're using a graft, you will use a hamstring graft.
Thank you.
Okay, and the key here is that you will put the graft here, and then you will make the graft come out twice. So on this side and on this side, which will replicate the conoid and trapezoid ligament. Okay.
3 centimeter from the AC joint is and 4.5 centimeter from the AC joint.
Fantastic. You guys know everything. I just have to drag it out of you, isn't it?
Yeah.
Okay. So this is one option, and the other option is an artificial graft. You can have a Lars graft, or you can have a surgery leg where the coracoid is is attached to the clavicle after reducing it. Okay. The good thing is that that ligament is still intact, so it holds everything together also, like I said. The complication of this procedure is what? This particular artificial graft?
Limited external rotation?
No, there's nothing wrong with external rotation.
No, sir. Don't know.
The blood supply of the coracoid is compromised there, isn't it? You put a tight graft, artificial graft around it, it is not going to heal, it's just going to stay there. So the complication is coracoid fractures.
Okay.
Okay, so if you do an artificial procedure, artificial graft, but that is what everybody does. Okay, so move on to the other one. Who wants to turn next?
Sir, one question from AC joint.
Yeah.
When you do the repair or reconstruction of CC ligaments, do we need to augment that with a plate or something else?
So why do you want to repair the ligament? There is no role of it healing at all. In the first 4 weeks, if you do whatever you do, it will heal. After 4 weeks, it's not going to heal. So why do you want to repair it?
He is asking for the initial 4 weeks.
Yeah, don't need to do that. If you bring it together with a screw or a plate, you bring it together, it will heal. You don't need to repair it.
Let's suppose we...
No, suppose. Evidence-based talks, okay? So, but tell me what your question is, yeah?
Okay, my question was, when we are repairing the CC ligaments, do we need to augment that repair with the plate or not?
No. So you need to hold the clavicle reduced. Even if you repair the ligaments, they're not strong enough because they're torn and their strength is entirely on the sutures, what you would put in there. So every time you want to repair them, which I would not recommend, and not recommend to answer in the exam also, but if you do repair them, you have to hold the clavicle where it should be. So you either put a Boswell screw or you put a hook plate to keep it there to allow it to heal. So you don't need to do that in the first 4 weeks. You don't need to play with the conoid trapezoid ligament. Just bring the clavicle down where it should be, reduce the AC joint, and then it will heal on its own. After 4 weeks, whatever you do, that's not going to heal anyway. So you have to augment it with something. And it's better to augment it with a hamstring graft than to do anything else. And if you have the option or a choice, you can put an artificial ligament on it, such as a surgery leg or a LAS ligament or something like that.
After a allograft or autograft, should we augment it also or not with a plate or a screw?
No, you don't need to.
No.
Yeah. So just a simple algorithm. So if we are managing AC joint disruption, so initial it's non-operative. So you keep the patient
you
sling.
need to know what type you're dealing with. So there are 6.
It's 1 or 2.
So 1 and
3B.
2, you will try to manage them non-operatively with physio and pain relief. In 3, if it's an athlete and high-profile sports person, you will repair it acutely. Otherwise, you will leave him alone or him or her alone and do physiotherapy and pain management. And if 6 weeks is still not settling, then you will do a chronic repair. Okay.
You said earlier that a repair is not a good option.
Chronic repair means you put an artificial ligament or graft around it, isn't it? I'm just using a terminology. So what you see them in the first 4 weeks. So it's an acute tear, which means that the conoid and trapezoid ligament has a potential of healing. So 1 and 2, you manage non-operatively with physio. 3, depending on the personality, you will operate or not operate, whether it's an athlete or not. And in 4, 5, and 6, you have to operate in the first 4 weeks. The 4 and 6 are emergencies. You have to do them as soon as possible because they are stuck and they will not reduce if you leave them long. Okay, so that's the management plan. Acutely, you can manage them with a non-anatomical or an anatomical procedure. A non-anatomical procedure, you can do whatever way the Weaver done procedure, but I don't do it, so you may get into trouble in the exam if you speak of it, especially if you get arguments if I'm talking to you. However, you can use the Bosworth or the hook plate, and you have to take them out to get full function. So that's the problem with these. So what people are doing now is arthroscopically putting an endobutton across it with a fiber wire. So you don't even have to open anything, and you just reduce it and pull it in and tie it in the first week. After 4 weeks, you have to do a supplementation of the conoid trapezoid ligament, i.e. a hamstring graft or a artificial graft such as surgery leg or LAS ligament. Is that clear?
Yes.
So we're not going to have a problem in the exams, is it?
What will you doing for the 5? 5 के लिए क्या कर रहे थे?
5 is acute repair within first 4 weeks.
Okay. Okay.
Because the conoid trapezoid will heal within the first 4 weeks if you reduce it.
Okay, fine.
Okay.
Thanks.
So next is this. So somebody else going to play? So this is a 29-year-old.
Sir, in the exam,
Repetition.
sir, one question. In the exam, we have asked about the how do you repair bank card repair in the open procedure. So yeah, this is the procedure that you said subscapular is as a capsule, and then should we proceed further? Should we ask further about the procedure? How do we do the bank card repair?
If I'm doing a bank card repair, I would do it arthroscopically. But if you're doing an open, then what you do is you open with a delta pectoral approach, okay, and then you split the subscap transversely, okay, and then you open the capsule. You have to open the capsule separate to the subscap. Once you open the capsule, you will be on the bank card straight away. You need to roughen the bone to allow the graft to repair. You can repair the graft with any kind of sutures and anchors you want to. Does that answer your question?
So graft, can we take the same coracoid graft or tricortical graft?
For a bank card repair is different. We're talking about Latarjet and bank card. Bank card is a soft tissue repair. So bank card repair, if you're doing soft tissue repair, whatever tissue is available, you will grab that into a suture and you will roughen your glenoid and you will attach it. Give me 2 minutes. Hey, just give me 2 minutes. Just stay there.
Okay. Okay.
Okay, so can anybody see this with picture? This is a 30-year-old athlete who plays tennis and has come to their clinic with saying he's got terribly painful.
We cannot see it. We are not able to see it.
Okay.
Yeah, we can see. You can see.
Now?
Yeah.
Okay, good. So this is a 32-year-old who's a tennis player and he comes to your clinic and says, I've got a very painful elbow. What do you do with these? So somebody else.
I will first.
So the reason I'm saying is I want all of you to talk. Okay, the exam is not failed because you don't have knowledge. The exam is failed because you don't have an answer prepared to say to the guys. So the more you practice talking, the better your chance of passing exams. Yeah? So who has not participated yet, can you talk? I don't mind only one person talking, but the process is in the exam you have to express yourself, and if you don't do it now amongst friends, I don't think so you're going to do it on the exam day.
Any volunteer?
Anyone?
Nobody wants to talk. Well, then don't regret that you didn't pass the exam, like this, because you have to talk. You have to learn to talk. अगर कुछ भी नहीं करते हो ना, सारा दिन एक दूसरे के साथ बैठे रहते हो, टेलीफोन पे भी कोई ना कोई प्रोसेस डिस्क्राइब करते रहो, बिकॉज एग्जाम में जो है ना जब सवाल पूछा जाए तो वो जैसे मेमोरी रिकॉल नहीं होती, सीधा हार्ड ड्राइव डेस्क से बिल्कुल स्ट्रेट अवे लफ्ज टू लफ्ज सुना दे उनको. अगर आप अपने लफ्ज खुद बनाओगे ना बहुत डिफिकल्ट हो जाता है.
Yes sir.
Yes sir.
So who wants to play? I don't mind.
I will take the proper history and examination of the patient.
Yeah.
After taking history, is there any traumatic cause or is there a traumatic cause?
So
then I will.
This gentleman has a painful elbow. The clue is that in the picture there is something happening to his elbow. He's done something.
Yeah.
It's called an elbow.
There is a elbow brace, or
The
then I
tennis
will.
elbow.
What? Sorry.
Javed is saying it is a tennis elbow brace.
Yes, it's an elbow clasp. It's a tennis. It's one of the epicondylitis braces, isn't it? So it's a brace for the epicondylitis. Okay.
Yeah.
So if you can see it, there's a jelly on the lateral side. So it's a lateral epicondylitis brace. So it's a tennis elbow brace, isn't it? So what is tennis elbow?
Tennis elbow is the epicondylitis of the lateral epicondyle, the origin of the extensor tendon.
No, it's not the origin of the extensor. The extensor tendon is highly higher up, isn't it? It's when it comes and crosses the epicondyle, then when it's rubbing the undersurface of it, that's caused problems.
Actually, it's epicondylitis.
Yes, so it is not from its origin, it's when it crosses.
Yes.
Okay.
Leading to leading to the
Degenerate.
extensor original inflammation.
Okay, so what's a Herschel lesion? Herschel lesion.
Herschel.
Yeah.
First time I
Haven't
heard
heard.
it.
Is what, sorry?
Haven't heard about it.
Yeah, you all wanted to talk about upper limb. I was trying to teach you stuff that I don't know so that we can all be on the same level. You want to all talk about upper limb. So I know a bit about upper limb. So when the tennis elbow, when there is detachment of the extensor carpi radialis brevis, which is the ECRP, when it detaches from its attachment, that's called an inertial lesion, isn't it? And there are 4 types. When it is bruising, when it's tearing. But a tennis elbow is an inertial lesion. Okay, that's what it is. You may not be
Can
asked.
you spell it?
Yeah, it's called NIRSHAL, inertial lesion.
Inertial. Okay, fine. Got it.
But maybe your examiner might not know. But Sufyan will know. He will ask you if he asks you tennis elbow. Like, okay.
Now we will definitely answer it.
So we will tell him that tennis elbow is the epicondylitis of the lateral epicondyle, but the inertial lesion is the tear of the
ECRB.
origin of the ECRB.
Yeah. Don't volunteer this information. When he asks, then you can tell him. Because if you volunteer information, then all the brownie points is going to go like, isn't it? So this is tennis elbow. So how do you diagnose tennis elbow? After history taking, what clinical examination do you need to confirm the diagnosis?
My test will be, I will perform the Cousin test. I will register I will put the wrist in flexion and then ask the patient to extend the wrist and against resistance. Or number 2, I will stretch the extensor tendon by flexing the wrist.
Passively.
There are the 2 tests.
So there's a test called the chair lift-off test. What is that?
Sorry?
Chair lift-off test.
Sir, lift-off test is I will. अब इसके लिए तो पढ़ा था, इसके लिए नहीं.
So when you have epicondylitis, whether it's medial or lateral, you ask the patient to put both hands on the arms of the chair and push himself off the chair. If he has pain, that means he's got epicondylitis, either the lateral or the medial side. Then you have to localize which side it is. But
Okay, fine.
Patient pushing himself off the chair to stand, and if you have pain,
Yes.
you have epicondylitis. Okay? Then you want to know whether it's lateral or medial, so he'll tell you that the lateral side is tender or the medial side is tender. If the lateral side is tender, then you do what is called, you just told me, the Mills and the Cousins test. Okay? So everybody needs to be clear of the Mills and Cousins test. Okay? So what test is this one?
This is Cousin test.
No, this is Cousin is against resistance. This is passively flexing it down, isn't it? If you passively flex it down and feel for tenderness, that's a Mills test. If you do it under resistance and ask the patient to lift his hand in resistance, then that's a Cousins test. Okay?
Yes.
Don't confuse this in the exam. It's very easy to confuse it. Okay?
Yeah.
So the easy way
I
to
was
remember,
telling the second figure.
yeah, the easiest way to remember is that tennis elbow is extensor problem, isn't it?
Yeah.
Yes.
Yeah. So if you are doing resisted extension and it's painful, then it's a Cousins test.
If you are stretching it, then it is Milch.
Yeah. So I was going to tell you. So passively stretching it, it's Mills. So C comes before M. It's an extensor. Therefore, C is always Cousins and M Mills is later, like I said. Yeah. So what do you do for golfers then?
The golfer, then we will will extend the wrist and ask him to flex the wrist against resistance.
What is it called?
I don't know the exact name of this.
No,
but
you
yes.
need to use your common sense. So if you're extending under resistance, it is called a Cousins test, right?
Yeah.
If you flex under resistance, it is called a reverse Cousins test, isn't it?
Okay. Sorry.
And the same is for the Mills test. If you're passively flexing it, it's a Mills test. If you're passively extending it, it's called a reverse Mills test.
Milch. Okay.
Okay? So what do you do with these people? How do you manage them?
I will advise him to take the rest and avoid the repeated activities which is doing harm, which is causing pain. And number 2 is the analgesic.
For how long?
4 to 6 weeks.
4 to 6 weeks.
Do you know why we do 6 weeks? मैं पहले भी बता चुका हूँ. हो सकता है कि just to relax and and made a bait of
6 weeks PGI का बताया था सर.
इसका
PGI का prosthetic joint infection का बताया था. CRP वो 6 weeks और एक आपने बताया था 6 weeks जो है वो
6 weeks है.
Soft tissue healing takes 6 weeks at least.
No, not really. You know, जो सर वाटसन जोन्स था ना, उसने सर्जन्स को बोला कि आप सब जो है ना फजूल टाइम वेस्ट करते हो, सारी ऑर्थोपेडिक्स में आपसे लेना चाहता हूँ. उन्होंने कहा आप पूरे यूके में क्या करोगे? तो उसने कहा मैं अपने सीनियर रजिस्ट्रार भेजूंगा. तो उसने अपने 6 सीनियर रजिस्ट्रार 6 इलाकों में भेज दिए. हर एक को वो एक हफ्ते बाद विजिट करता था. तो अगर मैं सीनियर रजिस्ट्रार था मैनचेस्टर में, तो मेरे पास कोई प्रॉब्लमेटिक केस होता था तो मैं बॉस को दिखाने के लिए 6 हफ्ते बाद लेके आता था उसको, जब बॉस मेरे पास आता था. तो ऑर्थोपेडिक्स में 6 हफ्ते इसलिए है कि वो 6 हफ्ते बॉस आता था अपने सीनियर रजिस्ट्रार से. There is no evidence, medical reason or anything else. You know, हम सब इसलिए करते हैं क्योंकि कहते हैं ना लकीर के फकीर जिसको कहते हैं. अरे बॉसेस जो है ना वो इंग्लैंड से ट्रेन होके गए हैं, वो जब भी हर चीज 6 हफ्ते में बुलाते हैं.
कुछ नहीं आए 6 हफ्ते.
सॉरी,
कुछ नहीं समझ आए हीलिंग का 6 हफ्ते.
ओके, सो कैसे ट्रीट करोगे? आप उसको रेस्ट करोगे, आप उसको जो है ना फिजियोथेरेपी ऑर्गेनाइज करोगे, और हो सकता है तो उसको क्लास भी दे दोगे. क्लास जो होता है ना, मूवमेंट, इट स्टॉप्स द मूवमेंट फ्रॉम द टचिंग द एपिकॉन्डाइल्स, देयरफॉर द पेन इज लेस. अगर वो 6 हफ्ते आपने उसको रेस्ट किया और वो ठीक हो गया तो अल्लाह खैर से. अगर वो ठीक नहीं हुआ तो फिर क्या करोगे उसके साथ?
Then operative.
नहीं, see that operative, non-operative and operative choices. Okay, so what are your non-operative choices?
So you can give steroid injection.
Okay, so because it's an inflammatory process and inflammation is going on, you can give a steroid injection. It will give both diagnostic and therapeutic values. It will get better.
In the one book it is written it is not an inflammatory reaction, it is just a degenerative tears in the extensor tendon. So there is no role of NSAIDs or steroids in it.
Okay, so it actually makes it worse. That's why I was going to come to it. The steroid actually makes it worse. It is a degenerative process. However, there is a healing process going on, and healing will involve inflammation, and therefore you will ask other cells to come and help it, even though it's degeneration. जैसे bone जो है ना, उसका कोई दिमाग नहीं होता है. जब उसकी कोई प्रॉब्लम होती है ना, तो वो हाइपरट्रोफी करता है, ऑस्टियोक्लास्टिक ब्लास्टिक एक्टिविटीज बढ़ा देता है. उसको समझ आती है कि मैं टूटा हुआ हूँ, आई हैव ब्रोकन, देयरफॉर इट मेक्स मोर बोन. आर्थराइटिस में भी यही होता है कि यू हैव गॉट आर्थराइटिस, सो द बोन मेक्स मोर बोन एंड यू हैव ऑस्टियोफाइट्स. The same is with degenerative condition. It does not understand what's happening, so all it does is communicates mechanically with the rest of the body by asking for the macrophages to come and clean itself. So there is an element of inflammation in tennis elbow and golfer's elbow, although predominantly it's a degenerative condition. Okay, so the role of steroid in tennis elbow and golfer's elbow is 0. Okay, however, if you tell this to your examiner in Pakistan, most of them will fail you. Okay.
Yes.
So the role of steroid injection in tennis and golfer's elbow is 0. It doesn't work. But you have to say this in the exam, that my first preference would be to do non-operative, which would be to activate modification of activities, physiotherapy, splintage, and possibly try a local anesthetic with steroid to see if it can work. Okay. And if it doesn't work, then you have a choice of surgical release. Surgical release is a more permanent process. Okay. So what is the modern management of tennis elbow and golfer's elbow?
Surgical release, either do epicondyle osteotomy or remove, or the shave of the tear part of the extensor tendon.
What I do is I take the common origin and slide it off. So inverted triangle बना के उसको मैं slide off करता हूँ. ठीक है. फिर उसके बाद I take a K-wire and I drill the epicondyle to release the venous tension that is causing the pain. Okay. And I take a curette and I will shave some of the epicondyle off with a curette.
सर ये ट्रायंगुलर फैशन वाला समझ नहीं आया कि वो किस तरह वो फिगर वगैरह से.
एपिकॉन्डाइल जो है ना वो आपका फोकस पॉइंट है, उससे एंटीरियरली और पोस्टीरियरली जो है ना, आई थिंक आई ड्रॉ इट एंड आई शो इट. जस्ट गिव मी अ सेकंड.
Yeah.
I will draw it and put it on WhatsApp for you, yeah?
Okay.
Just give me a second.
healing click.
मैंने आपको अब WhatsApp फोरम पे भेज दिया है, तो एपिकॉन्डाइल नजर आ रहा है? Can you see it?
1%.
WhatsApp फोरम पे एपिकॉन्डाइल नजर आ रहा है, और एपिकॉन्डाइल को पॉइंट बना के एंटीरियर पोस्टीरियरली जो है ना डिटैच करते हैं और कॉमन एक्सटेंसिव ओरिजिन को जो कॉन्डाइल के ऊपर होता है।
Okay.
ठीक है, इस पूरा को रिट्रैक्ट करते हैं तो नीचे जो है ना उसके नीचे रेडियल हेड और वो नजर आना चाहिए, यूर इन द जॉइंट। उसको रिवर्स करेंगे तो पीछे एक्सटेंसर कार्पा रेडियलिस ब्रेविस होता है जिसको आप साफ कर देते हैं, और इसको फिर ड्रिल भी कर देते हैं ताकि वेनस टेंशन को दूर किया जाए। ओके
Okay.
Sir, what is the role of
one final one and we'll call it a day. Okay, one final one. और जो
Okay.
क्या हुआ?
Sir, what is the role of debridement?
Of what?
As I have read through my book that initially, if you are supposed to do surgery, the debridement is enough.
No, you
Are
cannot
they-
just debride. You have to release the tension on the extensor origin. So you release it from the top. You turn it around, and the extensor carpi radialis brevis is the degenerative part which is rubbing against it, and it will release inflammatory cells all the time. So you need to clean that up to make sure that there is none of it left. Then you do microfracture of the epicondyle to release venous hypertension. So you do multiple procedures.
So can we repeat the clinical test for epicondylitis, cousin and reverse cousin?
So the Mills and cousin. So if you're looking at the extensor compartment, resistance against extension is a cousin. Resistance or passively flexing it is Mills. If you now passively resist flexion, then it's a reverse Mills. And if you passively extend the wrist, then it becomes a reverse cousins. And yeah,
Mills.
Happy?
Cousin.
Yes, sir.
So is it what the function of flexor is we are doing in the test?
I don't
Are
understand.
doing opposite to it?
Sorry?
Like the medial epicondylate is flexor epicondylitis. So we are flexing the wrist or we are extending the wrist in a reverse cousin?
So what it is if you look at the lateral side, you are resisting extension, and that's your Cousins test, yeah? If you now resist flexion, so instead of doing this test, the person is trying to flex, but you're stopping it from flex, and that's a reverse Cousins.
Reverse cousin. That is for medial epicondyle.
Yes, different. It's the same thing, but a different test. One you need extensor, the other one you need flexors, yeah?
Yeah.
Okay. Oh, and Mills is passive one.
So the same.
Yeah.
The Mills is passively flexing it, and the reverse Mills is passively extending it.
Okay.
Got it.
It is advanced form of disease.
So we are recording this. We have not got the cuff bit on it, so I will just repeat the cuff bit if you want me to do now, or we can do the next one, which I want to discuss. This is one of my favorite topics, actually.
Yeah. This is a X-ray AP and lateral view showing scapholunate ligament disruption and showing the Terry Thomas, classical Terry Thomas sign.
Who was Terry Thomas? That you mentioned him. Who was Terry Thomas?
Terry Thomas is an actor. He has teeth. He has all the teeth, but he has artificially color the center one black, so it looks like a absent teeth.
Yeah. So that's what it says. So if you were in America, what would you call this?
This is the DC deformity.
No, hang on. Let's look at this picture first. You now said Terry Thomas sign, isn't it?
This is a Terry Thomas sign. The scapholunate distance is more than 3 mm.
Okay, so if you were in America, what would you call this test then? So if you're in England or trained in England, you call it the Terry Thomas sign. If you're an American, what would you call this?
There is some actor, another name. What
yes,
is what
it's called the Madonna test. Madonna test. Madonna. Teeth missing in the middle. So it's called the Madonna sign in America, and it's called the Terry Thomas sign in England. Yeah. So what's the problem?
There will be a DC deformity in the lateral view. There the lunate will dorsally go dorsally. This is a dorsal intercalated segment instability.
Okay, so that's very good. Now explain the mechanics to me. How does it work? Why does it happen?
Yeah, I will explain it. The scaphoid has a natural tendency to the flex, and the trichoterm has a natural tendency to extend. The lunate is the key to both these. the scapholunate ligament, if it is disrupted, then the scaphoid will be flexed and the lunate will be extend. So it will be a DC deformity.
lunate को capitate जब तक push नहीं करेगा ना, जब तक जो है ना वो ना radius को flex उसको scaphoid को flex होने देगा और trapezium को extend होने देगा. The capitate is the keystone here. It allows, like you said, it makes the scaphoid flex and the trapezium extend because of the pressure from vertically downwards. So ये जो middle finger का जो है ना इसको press करता है तो इसकी वजह से scaphoid extend करता है और trapezium जो है वो flex करता है. So lunate जो है ना वो बहुत ही जिसको कहते हैं ना वक्त परस्त जिसको कहते हैं. It will follow the one जो जिसने उसका हाथ पकड़ा हुआ है, जिसने उसका हाथ पकड़ा हुआ है उसी की तरफ जाएगा. You understand that?
Yes.
Okay.
So अगर जो है scapholunate ligament कट गया है तो lunate trapezium को वो follow करेगा क्योंकि उसने उसका हाथ पकड़ा हुआ है, which means it will
go extend.
Exactly.
Extend.
And अगर scapholunate ligament चला गया, which is what is here, it will do what?
The lunate
उल्टा बोल दिया ना?
Extend हो जाएगा sir.
Very good. उल्टा बोल दिया. मैंने कहा बोलने दो, देखो क्या कहते हैं ये. Okay, so in a scapholunate deficiency, this is what the picture is. It is extending, isn't it?
Yeah.
Yeah. So if the lunate tracheal is missing and the scapholunate is intact, it will flex. So do you know what this principle is? This is called proximal intercalated segment and distal intercalated. Right? And depending on where the problem is, you can call it CID and CIND. Do you understand that?
Yeah, sir. It is a dissociative, chronic dissociative or any. There is a.
It says chronic instability dissociative and chronic instability non-dissociative. क्या मतलब है?
क्लास हो रही है.
Huh?
This concept we do not know. We have read it, but we don't go in detail of this.
That's an easy way of getting out. इस वाले एरिया में जो भी प्रॉब्लम होगी ना proximal row में, वो CID कहलाती है और इसके अलावा और कहीं भी होगी वो CIND कहलाती है.
Okay, sir.
ठीक है, that's easy.
Sir, again.
So जो CID होती है chronic instability dissociative वो proximal row में होती है. अगर multiple levels पे होती है ना तो CIND कहलाती है non-dissociative. It is a linked process in proximally. If you can see, okay, that's the key thing to understand is ये capitate जो है ना ये हर चीज को तबाह करने के लिए होता है. It wants to make everything. So we have to stop the capitate from driving down. Okay, so if you have a patient with a fracture or a non-fracture, then there are names are called snack and slack. You understand that? Do you understand snack and slack?
Slack region.
So we need to be a bit more careful, guys. We're doing some education. Can we stop our volume if there's things that we don't need to? Okay. So if you look here, scaphoid non-union, and it's an advanced collapse. And if you have got a scapholunate dissociation, it's got a slack wrist. Okay. The key is the capitate. In both cases, the capitate is trying to drive the two apart. Right? इनके बीच में आना चाहता है. So you have to do some sort of procedure to stop the capitate from coming down. Okay. So if you have a snack wrist, right, what would you do? What is the management of a snack wrist?
There will be an interpositional graft that's like an inlay or Rosset graft, fixed inlay or fixed graft. You will take a graft and
that is for scaphoid non-union. We're talking about scaphoid non-union advanced collapse. Now you've gone beyond the repair of scaphoids now, isn't it?
Then we have to fuse the scapholunate and the trapezium, STT fusion. So the capitate will not.
For a slack wrist, not for a snack wrist. I'll show you to you why. For a snack wrist, you take the scaphoid and do what is called a limited fusion or a four-corner fusion.
Okay.
Okay. So if I show you a picture, and okay, so that's the DC. Okay, we've already said that. You know, the lunate will follow. जिसका उसने हाथ पकड़ा उसकी तरफ हो जाता है. This is proximal row and this is distal row. This is called CID and this is called CIND. If you have got problems here, yeah. So VCD ये होता है इसमें. Yes. So if you have a scaphoid snack wrist, take the scaphoid out and you do a four-corner fusion. चार बोन को फ्यूज करते हैं ताकि कैपिटेट जो है ना वो लूनेट के ऊपर प्रेशर ना डाले, स्केफॉइड के ऊपर ना प्रेशर डाले. You do what is called a four corner fusion. If you have
What joints it is? What intercarpal joints you have fused in the four corner?
so it's lunate, capitate,
Okay, one,
and then tracheatrium and the trapezoid. 4.
two.
No, 4.
Okay.
So,
Lunotriquetral, lunocapitate,
yes.
trapezoid, and capitotrapezium.
Thank you. So 4 joints, yeah? So it's called a four corner fusion. You have fused all the 4 corners, which means the wrist now moves on the lunate. Yes? The wrist now moves on the lunate and the capitate does not drive it far. But the scaphoid was non-useful anyway, so we use that as a bone graft. So this is called a four corner fusion. However, if you see the scapholunate dissociation, then what you do is you do an STT arthrodesis, so scaphoid trapezium and trapezoid arthrodesis, to make a pillar to stop the capitate from coming down and flexing the lunate. Do you understand that?
Okay, sir. Yeah. Now we get to know about the snake and slack lesion. In the snake lesion, we do a four corner fusion. In the slack lesion, we will do STT fusion.
Yes. The reason for that is that you're making the lunate make the proximal row. Yeah. And by fusing all the bones together, it becomes a limited fusion and allows the whole thing to move together. Okay. However, if the capitate is driving and there's a space for it to drive through, you want to make a pillar to stop it from driving, so you do an STT arthrodesis. So now, the modern trend is that instead of doing a four-corner fusion, you should do a radial lunate fusion. So you take a scaphoid out, bring the lunate central, and then do a radial lunate fusion so that the whole corpus can then move around the lunate. So they don't do four-corner fusions anymore. They do lunate, but in your exam, I think most of your surgeons will do a limited fusion anyway. Like, okay, so you need to know that.
In the exam, it is the most favorite question of the examiner. In the arthritis, the radial lunate joint is spared. Why it is?
So because of the forces, the capitate is driving where the scaphoid is broken. It's not driving on the lunate, so that's the last part of the joint that will take the force. So if the scaphoid was here, right, the capitate will be driving on the scaphoid, so you get radioscaphoid arthritis first. The lunate is not taking direct force from the capitate. We have now made this to go on the lunate, but in normal reality, if you look at this picture here, when there is forces going from the capitate, it will press the scaphoid first, and you have these problems. This is not in direct line of the force.
Okay, fine, sir.
Yeah. Okay. So I think we should call it a day. We've had enough. Is that okay?
The interesting talking is going on.
Okay. So I have to do some work because I also have a house, a wife, and 2 children. I would be thrown out of my house. I'm going to do some family chores. I can come back in a few hours and do it for you if you want me to. We can do it at Pakistan time, 9 o'clock or something.
Yes, fine.
Okay, we are waiting.
Okay, so you tell me what topic you want to discuss first.
Upper limb, sir. Upper limb. It is whole of the upper limb. We should be very expert.
Okay, so I mean, the upper limb is a lot of stuff. What do you want to talk about, isn't it? So we've talked about arthritis of the shoulder. We've talked about cuff tears. And we'll talk about instability of the shoulder. Okay, we've talked about some elbows. So should we do dislocated elbows this evening?
Sir, something to learn about rheumatoid, because in the exam there is one station should be rheumatoid. There will be a swan neck, boutonniere, metacarpophalangeal joint subluxation, or DURAJ subluxation.
So if I can't do Zoom, we will do it on the WhatsApp, but we'll do rheumatoid today. Yeah.
Okay.
Okay, so I have not videoed the rotator cuff part of it. So for the sake of for you guys to have a copy, we'll go back to the rotator cuff. I'll just quickly say something so that you can remember what we need to do in the rotator cuff. Yeah. Otherwise, you will not have a copy of it. I'm just only saying this so you all guys know this, but just to make sure that it is in the copy of the video. So when you have a cuff tear on an X-ray, this is an X-ray of a skeletally mature person who is showing superior migration of the humerus, which gives me an indication that this patient may have a rotator cuff tear. We will investigate this by doing an ultrasound first. Once we do the ultrasound will tell us the anatomical position where the cuff is torn. So either the supraspinatus is gone, the supraspinatus infraspinatus is gone, or the subscapular is gone, or all of them have gone together. So once we do that, we need to know how big the tear is. The ultrasound will tell us whether it's a small, medium, large, or a massive tear. So large tears can be repaired. The massive goes into the unrepairable category. Okay. So then we need to know before we repair, if we've decided to repair, to do an MRI scan with the Gottlieb classification to know if there is atrophy and fat infiltration. If there is fat infiltration and atrophy, then this becomes a unrepairable or irreparable tear, even though there is a small amount of tear, or it's a less than 5 centimeter tear. So once we've decided what we want to repair, we just need to know the supraspinatus puts the ball back into the socket, so we need to reconstruct supraspinatus. So in my view, the superior migration is repaired by putting the cuff back into place. If you can't do it and you are normal joint and you are less than 65 years of age, then you would do a interposition kind of procedure, such as a balloon or a superior capsular reconstruction. If you're above 65 or you have arthritis with no cuff, you do a reverse shoulder. Okay, so these are some examples. This is superior capsular reconstruction. This is a graft, and this is a balloon, which is putting the ball back into the socket. Okay.
What is the procedure called for a primary repair? This is toe
repair. Trans-osseous equivalent. If you don't want to confuse the examiner or yourself, then just say a medial and lateral repair. I will put the footprint of the cuff in a large area so that it integrates into the tuberosity. A medial repair and a lateral repair, yeah, both. That's called a trans-osseous equivalent. But you don't need to remember toe repair. You just need to say that the big footprint.
Sir, one question.
Yeah.
Sir, for example, a cricketer visited your clinic and he is complaining of recurrent dislocation of shoulder.
Yes.
And he's telling you that what procedure you will advise, which never you can say compromise my activity as he's cricketer. What procedure you will advise, sir?
So we had this discussion earlier on the dislocation, but I would know what the problem is first. Is he multiple jointed or is he a traumatic dislocation? Now, if he's multiple jointed, then there is not a lot I can do that can never dislocate his shoulder. I can tighten this capsule for him after he's the age of 18 or 19, but nothing else is going to make him better. So he just needs to have rehab and physio or make a scapular patterning to allow the scapula move the way he should. If he has got a traumatic problem, i.e. he's got a bony injury, whether he's got a bony Bankart or he's got a Hill-Sachs lesion, then we've discussed this, that if it's less than 25%, it is not an engaging and it's an on-track lesion, I will do a Bankart repair. If it's an off-track lesion, then we do a Latarjet for him. So that's what I would recommend to him. Okay, so we were talking about, we were talking about reverse shoulders. So initially it was all medial, and this caused a notching. So they moved everything lateral, and this caused loosening of the screws at the base of the glenoid. So now we have compromised by having a joint rotation center and a reverse where it should be, and lateralize the humerus, which causes the deltoid wrap. And because of the deltoid wrap, we have function. Okay, and this is one of the examples where we have done reverse shoulder. So now if we have a shoulder that looks normal, but we didn't discuss that, okay. Yeah, so even if we have a normal shoulder, we decided we want to do a shoulder replacement, we have to do a CT scan of the glenoid. The glenoid is being classified by Tilly Walsh, which tells us that you can't do an anatomical shoulder in B2, B3, and a C glenoid. Okay? Yes, we also will have to do a reverse shoulder, but an A1 and A2, which means it's a concentric defect or a small defect like a B1, then you can still do an anatomical shoulder, provide the cuffs intact. Okay, and then we did discuss calcium tendonitis, but that's all in the video. So I will post this video on the forum for you to revise again. But my sincere advice to all of you is please discuss with each other. Imtihan wale din, you have to look up. You have to prepare the answers. You know, people who pass is not because they know more than you. People who pass is because they practice speaking. You have to speak, and you have to give your information to the examiner, and you have to do it in a very clever way. Please practice talking different topics. Even if you think you're perfect in it, talk with your colleagues. You know, बैठ के ये रिवाइज करना है कि बोलना क्या है. Knowledge तो सबके पास अल्लाह के शुक्र है माशाल्लाह सबके पास knowledge है. It's not the problem. The problem is people don't know how to say in the exam. Okay, so happy. We'll come back in the evening and we'll talk about rheumatoid then. Yeah.
Okay, sir. Thank you.
Thank you, sir. See you at 9.
Yeah.
Good luck, sir.
Fantastic.
So nice of you, sir.
नहीं, इम्तिहान पाकिस्तान में सबको इम्तिहान पास करना चाहिए, बहुत जरूरी है.
Yeah, sure.
Sure.